Hello everyone. Today we'll be talking about how to deal with diuretic resistance in heart failure. So let's say, for example, you gave 200 milligrams of Lasix to your patient and did not see much urine output. Despite giving him additional 25% albumin and bumetanide, patient did not have much response to that dose either. You're possibly dealing with diuretic resistance. To understand this lecture better, please watch my earlier lecture on how to use diuretics and pharmacokinetics of loop diuretics. Diuretic resistance has not been defined very well, but I found two definitions for it. First of them was failure of oral Lasix in a very high dose to increase sodium excretion by at least 90 millimole over 3 days, or 24-hour urine sodium less than 50 millimole per day. Simply put, your patient did not respond to high-dose loop diuretics. We talked about reasons for diuretic resistance in my previous lecture. Go ahead and review it. But in short, there can be problem with non-adherence to salt intake. There can be problem with absorption because of food and gut edema. There can be problem with delivery to the renal tubules because of decreased renal blood flow. And then there can be problem with secretions of loop diuretic into the lumen because of the problem with transporters. There can be increased sodium reabsorption because of neurohumoral activation and nephron remodeling. These are the two beautiful papers. If you want to review them, you'll have a pretty good idea about diuretic resistance. But one of the most common things that you have to rule out is if your patient is compliant with salt intake. And simply put, you can measure 24-hour urine, and if your 24-hour urine has more than 100 millimole of sodium, that means patient is non-compliant with sodium intake. If you remember your biochemistry, 100 millimoles is equivalent to 2 grams of sodium. So if the patient is eating more than 2 grams of sodium, well, his urine will have more than 100 millimoles of sodium. Nephron remodeling is one of the most important mechanisms for diuretic resistance, and it happens because your hypertrophy and hyperplasia in the distal convoluted tubules and upregulation of a lot of receptors there. The commonest one is sodium chloride cotransporter, which is inhibited by thiazides, epithelial sodium channels, ENaC, and chloride bicarb exchanger, pendrin. To deal with this upregulation of the receptors, what you can do is block these channels by your medications. For example, your sodium chloride cotransporter in DCT can be blocked by thiazides. Your ENaC channels can be blocked by spironolactone and amiloride, and chloride bicarb exchanger pendrin can be somewhat affected by acetazolamide. Sodium absorption happens mostly in your PCT, followed by thick ascending loop of Henle, and then somewhat in DCT and collecting duct. If you block your loop diuretics, you will certainly cause more natriuresis. However, blocking this will upregulate your other channels, which will counter the sodium loss. And the two important systems that do it is your neurohumoral activation, which is acute and subacute, and increased receptor number and activity, which is chronic, which is your nephron remodeling. Thiazides are the most important in this case, as they account for 75% of your diuretic resistance. Since DCT handle only 5% of sodium, the thiazides are not great at natriuresis by themselves. And if you block thiazides alone, you will have some upregulation of your ENaC channel, which will counter your sodium loss. Chlorothiazide also blocks some of the carbonic anhydrase in the PCT, but this effect is not very important when you use it alone because of sodium-potassium 2-chloride channel in thick ascending loop, which absorbs all the sodium that is not absorbed in your PCT. However, if you use this medication with loop diuretic, you can certainly cause more natriuresis. Thiazides can reduce proteinuria, and they also improve calcium reabsorption. So let's see what is the evidence that thiazide increase diuresis when used with loop diuretics. This study compared furosemide with furosemide and metolazone, and you can see that furosemide and metolazone result in more than 500 cc's of diuretic response per dose as compared to furosemide alone. However, there are not many randomized control trial on this. One recently published trial called Chlorotic trial added hydrochlorothiazide to intravenous Lasix in decompensated heart failure, and they found that the change in weight at 96 hours was -1 kilo if you compare hydrochlorothiazide with placebo. This was another randomized control trial which compared SGLT2 inhibitor and metolazone. Focus on the metolazone only. In 96 hours, it resulted in at least net negative by 4 liters when used with IV furosemide. And you can see that the response is much more than hydrochlorothiazide. This was another randomized control trial which compared furosemide plus metolazone with continuous infusion of Bumex and Lasix. And they found that furosemide plus metalazone had significantly higher urine output as compared to Bumex infusion or Lasix infusion. So thiazides help with decongestion when added to loop diuretic with diuretic resistant patient. However, one of the questions that you should be asking is thiazides are ineffective in advanced renal failure, especially with GFR less than 30. So let's see if addition of thiazides to loop diuretic in advanced CKD patient helps with natriuresis. In this study, the average GFR was 13, and they compared sham with torsemide and buthiazide. And you can already see that patients respond much better with torsemide as compared to sham. However, adding a thiazide adds more natriuretic power to torsemide. In another study, in advanced renal failure, Bumex with chlorthalidone compared to Bumex with placebo resulted in significantly more diuresis by the end of 30 days. So thiazides usually don't work with GFR less than 20, but with loop diuretics, they can work even with lower GFR. So which thiazides should you use for the best effect? In this meta-analysis, when metalazone was compared to chlorothiazide, there was no difference in net urine output between these two thiazides. In comparison of indapamide and metalazone, again, no significant differences were observed. This study found similar results with chlorothiazide and metalazone. However, chlorothiazide is a much more expensive drug, so in fact you can achieve similar results with much cheaper metalazone. The only randomized control trial that I could find was 3T trial, which compared metalazone, chlorothiazide and tolvaptan, and you can see there is no difference in 48 hours cumulative weight loss between metalazone and chlorothiazide. So to increase diuresis in patient with diuretic resistance, use PO metalazone, and if unable to take orally, use IV chlorothiazide. Hydrochlorothiazide has much lower rate of diuresis, and you can use that as well. The safety profile of all these thiazides are pretty similar. What about potassium loss with adding thiazides to loop diuretics? And this is a serious concern because you can sometimes lose up to 200 milliequivalents of potassium in a day if you add thiazides to loop in a good renal function. In the 3T trial, they found the rate of hypokalemia to be around 10 to 15% when using thiazides with loop diuretics. In the same systemic review and meta-analysis, the rate of hypokalemia was similar between metalazone and chlorothiazide. In the chlorotic trial, there was significant hypokalemia noted up to 40.6% when compared to only 16% in placebo group. However, the degree of very severe hypokalemia, potassium less than 2.5, was pretty much similar between two groups. So hypokalemia is common to all thiazides, especially when you add to loop diuretics. So you must monitor it closely and supplement aggressively. A very good article about physiology and pathophysiology of potassium homeostasis is in this article. The links are in the description below. I suggest that you go through it. What about the other diuretics like acetazolamide, amiloride, and spironolactone? Carbonic anhydrase plays a key role in PCT in sodium and bicarb absorption by splitting the CO2 into bicarb and hydrogen ion. This hydrogen ion is used for sodium exchange using your sodium hydrogen cotransporter. So this activity results in sodium absorption and bicarb generation. When you block this enzyme with acetazolamide, you lose more bicarb and sodium in the urine. Since more bicarb reaches the DCT, pendant cannot absorb chloride. However, acetazolamide is a very poor diuretic because the sodium that is not absorbed in the PCT is absorbed by the thick ascending loop of Henle. However, if you give it with loop diuretics, you should be able to increase sodium excretion. In this study, they compared Lasix along with 500 milligrams daily of acetazolamide. This was your ADVOR study, and they found that the absolute difference on second day was around 0.5 liters when they compared placebo to acetazolamide group, and about 98 millimoles of more sodium loss. There was also improvement in congestion score. However, it did not show any change in length of stay or mortality. There was no severe metabolic acidosis or hypokalemia compared to the controls. So the effects are modest, but they are certainly there. Since by using acetazolamide and loop diuretics, you have increased natriuresis. So if you add thiazides to the mix, you should be able to achieve even more diuresis. This has been studied in nephrotic syndrome, which certainly shows that there is increased sodium excretion when you combine all the three diuretics together. However, this has not been studied in congestive heart failure. So you can add acetazolamide if you need to improve diuresis, and many physicians will add acetazolamide to counter the alkalosis of loop diuretics. However, be cautious when using acetazolamide in patients with hypokalemia, CKD, cirrhosis, and COPD with chronic CO2 retention. What about amiloride and spironolactone? These medications are potassium sparing, so possibly can help with hypokalemia. Amiloride has been studied mostly in hypertension and nephrotic syndrome and not in heart failure. And trimetrine, which is another potassium sparing diuretic, is nephrotoxic, so it's not used in heart failure patients. Spironolactone is an amazing molecule because it does not need to be filtered into the tubules like other diuretics. Aldosterone upregulates sodium-potassium ATPase, ENaC channel, and potassium channel in the distal convoluted tubule and early collecting ducts. For its mechanism, I have discussed it in great details in an earlier lecture, but in short, generation of sodium concentration gradient by sodium-potassium ATPase results in absorption of sodium, and because of increased concentration and electrical gradient, you are able to excrete potassium and hydrogen ion, and sodium-potassium ATPase maintain this gradient so that you are absorbing sodium and losing potassium and hydrogen ions. When you block this channel with spironolactone, you cannot exchange sodium and potassium, so you get hyperkalemia, and since you cannot get rid of hydrogen ion, you get acidosis, but you do lose sodium ions. Trimethoprim acts similarly by blocking this channel, so you can see hyperkalemia when you take this antibiotic. Real study and emphasis HF trial has shown to improve morbidity and mortality in patients with heart failure with reduced EF less than 35% and NYHA class 2 to 4. Because of this, hypothesis was made that higher dose of spironolactone might result in even better response in acute congestive heart failure. In Athena heart failure trial, they compared 100 milligrams of spironolactone with 25 milligrams of usual dose, and they did not find any difference in death or heart failure rehospitalizations. So use only 25 milligrams of spironolactone for now till more data is available. Hyperkalemia in spironolactone is common and it's seen up to 9.3% of the patient. However, only half of this is related to spironolactone. So the incidence of hyperkalemia because of MRAs is around 4.5%. But since you're using it with loop diuretics which cause hypokalemia, let's see what is the new incidence of hyperkalemia. This study looked at more than 3,000 patients with spironolactone and loop diuretics and found that you still develop hyperkalemia when you use loop diuretic and spironolactone. The effect of this increases as your GFR drops. The rate of hyperkalemia are certainly lower when given with loops, but they do occur. So sequential nephron blockade is a good way of dealing with diuretic resistance. The potential benefit include relief of fluid overload and edema, weight loss, and symptom improvement, along with decrease in system congestion. However, there are potential adverse effects of this method, most important of them being hypokalemia and worsening renal function. To avoid it, start with low dose and escalate it up as your patient need. So for example, if you're using metalazone, start at 5 and escalate up to 10 as needed. Or if you do not have any PO access, use chlorothiazide at 250 and escalate it to 500. Use spironolactone 25 mg as per goal-directed medical therapy. This will also help you as a potassium sparing diuretic, and it will give you benefit of aldosterone antagonism. You can add acetazolamide to the regimen if you need it. To summarize, when you suspect diuretic resistance, go through a differential. Make sure that you check for non-compliance, check for NSAID use. Adding thiazide is the next step. Use PO metalazone, and if unable to take orally, use IV chlorothiazide. Watch for hypokalemia and other electrolyte abnormalities and monitor your renal function. Adding acetazolamide can help you diurese further. It can help with reducing alkalosis from loop diuretics. Continue your spironolactone at 25 milligrams daily as per your goal-directed medical therapy, and make sure that you are monitoring your potassium for hyperkalemia. We are not done yet. There are other interesting things like stopping the neurohormonal activation and other mechanisms which can help with natriuresis in your patient. We'll talk about this in next lecture. The references are in the description below. Thank you.